We are a national nonprofit organization that supports the liver community with education, support, resources, and advocacy. Thank you for the opportunity to train you on novel approaches on treating hepatitis C in rural settings. This is the second session in this year's special speaker series. Our major goal of this training is to make an impact on eliminating hepatitis C as a disease burden, particularly in response to the intersection of viral hepatitis C and the opioid epidemic. It is with great pleasure that I get to introduce this evening's special speaker, Dr. Tuesday Stainbrook. Dr. Stainbrook is board certified in infectious diseases, internal medicine, and HIV. She is dedicated to the health and well-being of all of her patients. She completed an accelerated internal medicine residency at Doctors Hospital in Columbus, Ohio, as well as an infectious disease fellowship at the University of Pittsburgh in Pittsburgh, Pennsylvania. Dr. Stainbrook also obtained her master's in public health from the University of Pittsburgh while completing her fellowship. Dr. Stainbrook is a member of the American Osteopathic Association, Pennsylvania Osteopathic Medical Association, Infectious Disease Society of America, American Academy of Wound Management, and the American Academy of HIV Medicine. She holds multiple certifications and licensures and has received numerous honors. I am going to, so this is a small group, so I encourage everyone, if they wish, to unmute themselves and make this informal and make comments and questions as we go along. Okay, take it away, Dr. Stainbrook.
I am so sorry. I was muted. And thank you, Allison, again, for that introduction. So tonight we're going to talk about hepatitis C and the objectives. We're going to go over the current epidemic of hepatitis C, identify those at risk for hepatitis C, identify places that are in need of hepatitis C testing, and going to go through the barriers of screening and how we can overcome the barriers of screening and the barriers to diagnosis, and how to link people to care to get treated. We'll go a little bit over addressing the stigma, and then we're just going to go a little bit over the role of harm reduction with hepatitis C. So hepatitis C is a viral infection that is actually a picture of the virus. It can lead to liver disease, but it also can affect your body in many ways. I mean, it's been linked to increased depression. It's been linked to increased risk of diabetes, and it can affect your joints, your kidneys. So it's a disease that doesn't just affect the liver, but it can affect your entire body. And there's currently 2.4 million Americans living with hepatitis C. A few years ago, we used to see nothing but baby boomers that would walk into our office and get treated. That was when treatment was actually much easier because the people were searching for a treatment cure and they were coming into our office. Unfortunately, now the entire Hep C paradigm has changed, and that's due to the opioid epidemic. And now the IV drug use actually accounts for 70% of new hepatitis C infections. So what we're seeing now are people who are younger and addicted to drugs. So those who are addicted to drugs, 40% of people actually know that they have hepatitis C. You'll see that when you go to methadone treatment facilities or Suboxone, about 40% already know and just haven't even sought care. And then a study showed that in 2017, new Hep C 63%. So it's similar to the previous slide where I said 70% of people have hepatitis C due to IV drug use. So has become our priority population that we're now searching to treat. And unfortunately, those with a history of IV drug use tend to go untreated. And the reason why is there's many reasons, but some of the most common is because a lot of times they're transient. They're on homeless at times. And because of that, not having an address, they're 91% less likely to be treated for hepatitis C. Another reason that they're often not treated is because mostly because they have ongoing drug use. And many people don't want to treat people who have ongoing drug use. So they are 74% less likely to be treated if they continue with their drug use. And the reasons why people don't tend to treat because of the drug use is they are worried that the patient can't take their medication, and so there's going to be poor adherence. And we know that this really isn't true. Due to our HIV studies, we have found that people who have HIV and drug use, they do just as well on treatment than those who don't have IV drug use. So that actually is not should be a real concern about adherence. But of course, it should be something important that you talk to them about, because the only way you can be cured is to take the medication. So adherence definitely is a priority, but it's something that people who are doing drugs can adhere to. The other reason people who are doing drugs don't often get treatment is because the perception that their substance abuse, the heroin abuse or the methamphetamine may affect the treatment outcomes. And we know that from several studies that that's not true. They do just as well as people who do not have IV drug use. The only caveat to that is we tend to lose people more. So our treatment outcomes don't look as good. And we'll show you that with my own study, but they do well if you can find them. There's also concerns of the risk of hepatitis C and reinfection, and that's a real concern. But many studies have shown that probably the risk of reinfection is actually only about 5%. So I do think that's low. And again, it's a conversation that should be had with anyone who is being treated, that they can be reinfected. It's not like other diseases where you make an antibody and it fights the virus the next time you're infected. So you can be reinfected. So there are several societies who actually recommend that if you have hepatitis C and you're still ongoing drug use, that you should be treated for hepatitis C. Actually, the only contraindication for hepatitis C treatment is having a lifespan less than 6 months. It is now recommended by the Liver Disease, the Infectious Disease Society, the American Society of Addiction Medicine, the World Health Organization. All these organizations recommend treatment of hepatitis C even if there's ongoing drug use or there's ongoing alcohol use. And that is completely different than it used to be regarding the alcohol use, but now it's actually recommended that any active IV drug use or alcohol use and hep C be treated. So where are these people now that have hepatitis C? What we're seeing is a lot of them are at medication-assisted treatment facilities, such as methadone clinics, Suboxone clinics, Vivitrol clinics, and then also a lot of them are also seen in mental health facilities. But what we're seeing, though, is we're not reaching them. And there's a lot of reasons why we're not reaching them and our numbers are not going down. One of the main reasons is there's very few physicians willing to treat these individuals. They're difficult to treat. They don't follow up. They don't get their blood work. And they're hard to find. So there's not, you have to really want to treat it and run after these people to actually do the treatment. So limited number of physicians. The treatment facilities are often hard to get into to test. They're in Philadelphia. They do test for hepatitis B and C upon getting into a facility. Until this year, only till this year, they didn't even check for hepatitis C. So they are, and I don't know if they've started, but now treatment facilities are now required to check for hep C. But until this year, the state did not mandate them to be tested. So hopefully now we're going to see, as that rolls out, we're going to see more people who are aware of their diagnosis, because a lot of people are not even aware of their diagnosis. Public transportation is definitely a barrier to treatment. People do not have, especially in rural areas, they do not have cars. There's not much public transportation available, and they can't get to the treatment providers. Then there's a ton of individual barriers that prevent treatment. Often people are worried about money. They're worried that they're going to have co-pays for blood work, co-pays for the medication, co-pays for radiology or the doctor's appointment. Money is always a big issue when it comes to this population. Time too, because a lot of times they're trying to juggle a job, their methadone clinic, getting there and getting home for their children. And so time is often, we see people go in there, they don't even sometimes have time to get the Hep C screen, and they're out. So time is often a challenge also. Having childcare, because when you have a health ride, you're not allowed to bring your children on with the health ride. So childcare and leaving children at home, that's often a problem to getting to treatment providers. Another big issue we see is mental health problems. There's a lot of depression and anxiety in this population, a lot of paranoia due to methamphetamine use. So they're a difficult population to reach and get and to build trust with. Again, we talked about homelessness, the transient. Where do you send medication when you're going to, if you decide you're going to do the hepatitis C treatment? If they don't have an address, where do you send it to? So you have to be aware of this, and then maybe send it to your office or to a friend's house or something. But it's often becomes a challenge, because if they can't have the transportation to your office, then they can't get the medication. And then another barrier to treatment I see with individuals is priority. With hepatitis C, you don't feel sick. Most people do not feel sick with hepatitis C. Most people don't have any symptoms. So it's not bothering them. And they have so much else going on in their life, and their life is chaotic, that is not a priority. So how we change these and make it a priority, I'm open to suggestions, because it is very difficult, because we try to tell them that their health should be a priority, but at the time when they're going to a treatment, it's often not the priority. And in rural areas are definitely disproportionately affected by the opioid epidemic. We have a lot more drug use in the area. Therefore, we have a lot more hepatitis C in the area, and we have a lot more other problems with barriers. So there's a lot of also stigma for hepatitis C. I've had people scream, cry, and when they find out they have hepatitis C. So there's stigma they feel from themselves, from society, from health providers. And we need to try to reach out to them and let them know that, hepatitis C is actually a treatable disease. It's easy to treat, can be done in no time, because there is definitely a stigma when it comes to them, because many people who we now see are getting the infection due to IV drug use. And so they're frequently blamed for getting hepatitis C. So try to avoid those stereotypes and be kind with them. They also, like I said before, depression, anxiety is very high in this population. And then what I'm also seeing is that people are not aware of that there's a cure. They still think that the treatment is the shot, where it was what they used to call chemotherapy, that had lots of side effects. So we try to educate that there is a very good treatment now that is just pills, short-term treatment with very minimal side effects. So I'm going to go through the next slides, exactly what we did in 2017. So what we did was we wanted to identify, at least screen 3,000 individuals over 3 years. And we actually did that. We screened 3,000 individuals. And then when we went back, we realized that some people had multiple screens because, like I said, this population is transient. And we would maybe go to a facility in one county, and 3 months later, we go to a facility in another county, and that individual is there again. And if they were like, you know, we didn't get our results, can we get screened again? So we did have a few multiple screens, and then we found out we had a few people that were from Canada that were in there too. So we ended up doing our statistics on 2,995 people. And this is a map of PA. There's actually 67 counties in Pennsylvania, and we hit 53 of them. So at least one individual was from someplace in Pennsylvania in 53 out of 67 counties, and then plus a few from Canada. So I thought we did a very good job of trying to represent the whole Pennsylvania state. And oops, sorry about that. But most of it was rural Pennsylvania. So what we thought was important for our study was that we were trying to do at-risk rural patients. And because the disease burden is there, they cannot get to facilities for treatment. And this is what we concentrated on. And why we concentrated on it was because even though we have less people than we had a few years ago, mortality is still high regarding hepatitis C deaths. So we wanted to try to go for that World Health Organization goal to try to treat as many as possible. So what we did was we actually went to medicated assisted treatment facilities and community events. And we would go there, we'd start at the facility at 4:30 in the morning and test till 1 o'clock in the afternoon, about 2 to 4 times a month. Of course, the community events were not that early. We would do the antibody with the oral quick hep C testing. And what I started doing in the very beginning is that I would, after we'd get a positive screen, I would go back to the facility, meet with them, and try to treat them at the facility. I did this for probably a year, and I realized as I sat in the facility and they ran past me and said they didn't have time, that it wasn't going to work this way either. They were just limited on time. So that's when we implemented the telemedicine. So about halfway through, we implemented a whole telemedicine before COVID. We had got our telemedicine set up and everything. And instead of us going there for the treatment, we would hook them up through the telemedicine, which we'll talk a little bit more about. And so what we did was we went to 36 medication assisted treatment facilities, and then we did 23 community events. And what we found, of course, is that people at medication assisted treatment facilities were more likely to have hepatitis C. No big surprise there. We had 730 positives out of the 2,995, and 653 of them were at medication assisted facilities, and 77 were at community events. So this slide kind of tells the whole story there. So we had the 730 hep C antibodies. So the second step is after you have an antibody, which just shows you that you were exposed to hepatitis C, doesn't tell you that you have chronic hepatitis C. An antibody can be positive if you had previous treatment. An antibody can be positive if you were cleared yourself. So the next step would be to check to see if they have a viral load. So it's a hepatitis C viral RNA test. So that would require someone to go out and get blood work. And so out of the 730, only 371 people went out and got blood work and did the second step. And out of that, quite a few of them, 272 were actually positive with, met the criteria of chronic hepatitis C, meaning they had a positive viral load. And then 249 actually kind of met with us in some capacity. So maybe they had, and they were negative viral load, we'd call them. Otherwise, if they had a positive viral load, we did either met with them at our office or at the facility, or I would do the telemedicine. And after that, and we've actually skipped this step, our next step here through time, we've learned. But after that, we would make them, because that's all we ordered was a viral load. And then we would require them to go back out to the lab and get all the blood work, which is quite a bit of blood work they needed for hepatitis C treatment. And that's what we've now we've decided to skip. So if a person has a positive antibody now, we just do all the blood work they would need for treatment, because we realize that we lose 50% or more going back out and getting that blood work. So then we're trying to minimize the blood work. Does it cost the healthcare probably more money? Yes, because you've got people who have had treatment before, or maybe cleared themselves, getting all this other blood work that's probably not necessary. But we are realizing it is capturing more people. But back when I was doing my study, that's not how we did it. We would give them a second blood work sheet. They would go back out and get the blood work. And you can see that's where we really lost a lot of people. And we only got to initiate treatment on 102 people out of that 730. So then it was difficult. A lot of times, once they get their medicine, we can't find them again. So what we were able to find is 49 people to show that they had an SVR. We know of only one person who actually failed treatment and was not cured. And he did go on, and we treated him again and he was cured. But we can assume, though, that with the new antivirals, they're so highly effective that probably if they 102 initiated it and they took their medicine, probably 102 had an SVR. But we only had 49 actually complete, and we were able to find. And this is just kind of going over it again. Just basically, I want to say that the loss to follow up, we had 46 in the MAT, 46 in the MAT and 6 in the non-MAT group. So some obstacles that we actually faced was of course, the public transportation. Most people did not have a car. They couldn't afford a car. A lot of it was a lot of financial burdens and stuff. And so what we realized that it would be nice, though, if this was all bundled in the treatment facility. And if they had harm reduction to prevent reinfection. It would also be nice if we had social and mental health there also. And we have tried to expand that into our program, but it's still a difficult thing to do. And let's see, what else did we do? Oh, talking about telemedicine now. So what we did was we actually did this before COVID-19, but now with COVID-19, every practice has telemedicine, and because of that, we have actually, people have done studies to see if treating hepatitis C through telemedicine is just as effective as standard in-person clinic trials, in clinic visits. And what we're seeing is it's just as effective as a person coming into your office. And the reason why is there is actually really minimal laboratory monitoring when it comes to the new medication, because they're pangenotypic. It's really easy. Now you still have to get a genotype for the insurance, but I mean, it's really is nice and easy. And with the telemedicine technology now, so what we have is we have a bi-directional text messaging where people can text us all the time. We have a video capability. So it's just so much easier. We try to stay clear of the telephone visits because we like to see the people, and also because of COVID and the prerequisites are actually they are expiring. That's what I'll say. The insurance companies a lot of times are no longer paying for telephone visits, so we do try to get them on the app and do a telemedicine visit with them. So what does telemedicine visit if you want to do treatment for hepatitis C? The first visit is usually going over the risk factors, finding out what exactly they need, how long they've had hepatitis C, their history, and then, you know, making sure that they have all their blood work and everything. And then there's on treatment visits. And then we usually tend to have a post-treatment visit to tell them if they were cured and stuff. So one of the things that I found was a challenge was making sure that I did not treat anyone who was severely cirrhotic or had other medical problems through telemedicine. So it's you know, it's something that it's difficult to do. But so what we chose to do and what we choose to do is we actually require the patient to have a physical exam by somebody else and send it to us. And I tell that to the patients because I say, yeah, I know you think you have 2 lungs and you have an abdomen, but I want to make sure you have that heart and 2 lungs. So they usually laugh and they understand that, because also I don't want to treat someone who's severely cirrhotic, and usually you can tell by blood work, but I still don't want to do that and have them, you know, decompensate on me. So we try to make sure that another doctor actually looks at the person also. But on physical exam, it's really limited when you're looking at televideo. I mean, for stigmas of cirrhosis, I mean, you're looking at their eyes to make sure they're not, you know, orange, but there's not a lot of things you can tell if someone's cirrhotic by physical exam. So that's something that, you know, have to be aware of. But you can usually tell if someone's cirrhotic by looking at their blood work. They'll have a low white blood cell count. They'll have low platelets. You should ask them if they have edema, if they're having swelling, and ask them about their stomach and if they have abdominal pain and stuff. Also, we often ask them about their joints because you can have extrahepatic manifestations, like I said, with their joints. It can cause arthritis. So we often ask that also. We do a complete review of systems usually. And we also review if they've ever had prior treatment of hepatitis C, their alcohol use, their current drug use, if they've been clean, what they're doing, if they're smoking. We often ask them if they would like to stop smoking, and we offer treatment options to help them stop smoking also. We go through the medication, the vaccinations, birth control, kind of everything you would do in your office. So the labs that we now actually offer after the first antibody test, we get a CBC, CMP, INR. Do not know why the state is requiring an INR, but they do. So that is, we get that. Always screen for hepatitis B, and that's with a hepatitis B surface antigen and antibody, and then a core antibody. We get a hepatitis A total. It's an IgM plus IgG, because if a lot of times they're not aware if they had hepatitis A vaccine, and if they do have a negative hepatitis A antibody, then we will vaccinate them just as if they have a negative hepatitis B surface antibody, we will vaccinate. And what we try to do is send it to a pharmacy. That becomes a challenge because a lot of pharmacies don't have hepatitis A and B vaccinations, but we try to reach out to pharmacies and see if they can get it. We assess their fibrosis score and how much liver damage with a FibroSure or a FIB4. We also check for HIV and let them know we're checking for HIV. And we also let them know that we are screening them for other STDs. That's something different. I know a lot of people don't do for Hep C, but we do because we know that chlamydia and gonorrhea and syphilis are at the highest rates in the last 10 years. So we definitely screen for that also. And if they're females, we do a pregnancy test. We provide education about reinfection. We offer, they're usually in drug and alcohol counseling at the time when we're seeing them. And we talk about harm reduction. And then we often also ask them about if they would like PrEP for to prevent HIV. The CDC is actually recommending that those who have IV drug use be offered PrEP. So these are the two medications that are the pangenotypic that we tend to prescribe. So that means they can be used in any genotype, 1, 2, 3, or 4. These are the four of them, the genotypes most commonly seen in the United States. The differences is, remember, the Mavyret is actually a protease inhibitor, which is important when you're talking about cirrhotics. And the treatment length, the Mavyret's 8 weeks, the Epclusa is 12 weeks. The Mavyret is 3 pills all at once with a little bit of food. You don't have to take it with a whole meal, just a little bit of food. The Epclusa you don't have to take with food. PPIs, there is a must be dosed at different times with the Epclusa. There's no interaction with Mavyret, but there is an interaction with birth control pills that have ethylene estradiol in, but there's no interactions with Epclusa. Both of them, so they're just little differences. Both of them are just as effective as each other. They're 98 to 99% effective in curing hepatitis C. Both of them have this very similar side effects. 10% headache or fatigue. But overall, I'd say that most people actually feel better on the medication because they no longer have the viremia. But how do I choose between the two? If someone is an F4 cirrhotic, we tend to use the generic Epclusa because that one comes in generic. If they are not cirrhotic, then I actually give people a choice. I ask them, would you like 3 pills a day with some food for 8 weeks, or do you just want 1 pill a day for 12 weeks? Because some people want to just get it done quickly, and other people don't like to take pills, and so they like the 1 pill. So I just kind of give them a choice. I mean, also I look at their medication. If there's drug interactions, then maybe I will choose one above the other, but otherwise it's usually given a patient's choice. While they're on treatment, there really is no lab monitoring required. If someone's diabetic or on Coumadin, I would recommend just watching that closely because there can be some interaction with the medication. It's not contraindicated, but something you need to watch closely. We do mid-treatment labs just because we've always done that, and I've treated for so many years. And I also think that it helps people see that it's working. But if they don't get it, which some people don't, that's fine also. We usually get end of the treatment labs also just to see if it worked. We like those, especially if you didn't get mid-treatment labs. And then we tell people, about the cure. Cure is considered finishing your medication, having a negative viral load, and then 3 months later, having that negative viral load. That's where we lose people too, because in 3 months, they're not around. But that is optimal, is to try to get a blood work at 3 months. And we often, with the viral load, we also get the liver function test too, but they're usually pretty good at that too. They're usually normal. Follow up after cure. Really, if you are not an F3 or an F4, you can say, hey, goodbye. You know, you're cured, but please also tell them about the hepatitis C antibody, that their antibody, just because they're treated doesn't mean their antibody is going to go away. An antibody is a memory cell. Sorry, my phone's ringing. An antibody is a memory cell, so it's not going to go away. And sometimes physicians or other providers don't realize that that you have to get a viral load to see if someone has chronic hepatitis C. If they do have F3 or F4, then they are at risk for liver cancer. And those are the patients that you're going to need to continue to monitor with a ultrasound every 6 to 12 months, usually 6 months, especially if they're F4s, along with often liver function tests and alpha beta protein. We also recommend, again, trying to avoid telling them to avoid excess alcohol or drug use, and try to actually continue with their therapy and treatment. Harm reduction, we often go over with them also about sharing, not sharing needles, try to use sterile injection equipment. Unfortunately, in my area, there is no harm reduction at all here. But if they must share needles, then telling them to bleach it, letting them know that a virus can live outside the body. So, you know, bleach around the area that you are, if you are using. If you're going to get a tattoo, to use sterile ink pots and new needles. We tell them to avoid sharing toothbrushes, razors, nail clippers, because that could have some blood on it. Avoid sharing straws, because you can get hepatitis C by even snorting. And crack pots, also avoid sharing that because of cracked lips and bleeding. We tell people to use condoms, lubrication. We actually have condoms in our office to give out if they would like them. And we do tests for all the STIs. So hepatitis C can be transmitted through sex, but it needs to be blood to blood. So it's low, but it can happen through sex, especially with MSM. It can happen with any time a person's bleeding and two people are bleeding. So it actually is increased risk when you have other sexually transmitted diseases, increased risk in if a person has HIV. So again, we recommend getting tested for other STIs. And then, you know, we often tell them about reducing their alcohol along with it. And then we recommend the hepatitis A and B vaccines. Any questions so far? All
No,
right.
thank you.
Okay. Yep. So now I'm just going to go over a case study. This is actually one of our patients. He's a 29-year-old male who has a history of IV drug use, currently on methadone. Was told by a friend that who he shared. He didn't think he was positive, but he shared he was positive. We did a test. It was positive. We also offered him an HIV test, which was negative. He was counseled on Hep C, and we told him to download our app, which is www.telehep.com. and we gave him a blood work order. And again, this is what we do now. We gave him a blood work order that has everything that we need to get to order his medication. So he went to a local hospital and he got his blood work. He is a genotype 3. His viral load is 3.5 million. His LFTs are actually normal, 27 and 24. So they're good. His hepatitis C surface antibody is positive. His hepatitis surface antigen is negative. His hepatitis C core antibody was negative too. So he has been vaccinated. He's young, so I expected that. His platelets are normal. So that makes me think he's not cirrhotic. The lab, I had ordered a FiberSure, but the lab forgot to do it. So the insurance do take FIB-4s. So we figured out his FIB-4. And he was set up with it for a telemedicine appointment. And we reviewed his medication. He takes methadone, 45 milligrams. We asked him to go to his local doctor or even get a physical exam from the methadone clinic and send it to us. And all they do is upload it to the app. We ordered an ultrasound at the local office. We offered him PrEP, which he declined. The other thing that we do, and if you want to do this, is also we ask for multiple numbers and emails. We ask for, hey, if we can't reach you, is there some other family member who can reach that we can contact? So we asked him, how long is he going to be at this facility? Does he think he's going to be moving? And who we can contact. So we did a FIB-4 and it was 0.6, which means he is at very low risk for advanced liver disease. So my treatment options would be the Mavyret or the Epclusa. I went through his drugs and really he's only on methadone. So, and there's no drug interaction with the methadone. But keep in mind that you have to be mindful of proton pump inhibitors, birth control, and there's certain seizure medications that have drug interactions. So since he has neither one of those interact with it, so I'm still saying, hey, I can use Mavyret or Epclusa. His fibrosis score is pretty much 0. So I think, hey, I can now use Mavyret or Epclusa because if it was an F4, I would use the generic Epclusa. But so I ask him, he is given an option of 1 pill a day for 12 weeks or 3 pills daily for 8 weeks with some food. He chooses, I don't know what he chooses, but we could say he chooses Mavyret. And the medication is ordered through a specialty pharmacy, and they're the ones who do the prior auth, and it's delivered to his house. We often ask them to call us when they get it at the house, and we also have the pharmacy email us when it's sent to their house. We send scripts for his hepatitis A vaccine to his local pharmacy, and then we set him up for our telemedicine. Because this is his second telemedicine visit, we actually review his medication he's got. We review how long he's been going to take it. We're going to review where he stores it and what he does if he misses a dose. And then we're also going to tell him, please don't start any new medication without us knowing. So just call us and let us know that if you miss something. So if he was on Mavyret and he misses a dose, which is 3 tablets, less than 18 hours after his usual time, then he needs to take those 3 tablets as soon as possible. If he misses 3 tablets more than 18 hours from his usual time, then he's not going to take it that day's dose. And what we do is we just tack it on in the end. We make sure they take all their medication, but if they miss a day, they miss a day. And then they just get an extra day on their end. If we miss a dose of the Epclusa, again, you only take 1 pill a day. So if they miss a dose, then they just get an extra dose at the end of their treatment. So sometimes it's more than 12 weeks, it may be 12 and a half weeks, or maybe 8 and a half weeks, because we want them to take all their medication. So it's all gone. Then I ordered a blood work for 4 weeks. Again, this is not mandatory. You don't have to do the 4-week blood work. What I ordered was a hepatitis C viral load and liver function test. We mail it or we fax it to his hospital of choice. And then we usually give him an appointment for end of treatment. At the end of treatment, we again review if he's had any side effects, and we review if he's missed any doses, review his current blood work, his current medication, and then he's given again a lab sheet for end of treatment, and then he's given a lab sheet for 3 months after treatment. And that's how easy it is. Any questions?
No, thank you.
All right.